All right. Good. Good morning, everyone. Thank you so much for coming today. We want to go ahead and get it started off with some questions from last session that we had. I got some answers for everyone. So I really like this method. So if you have any other questions during the course about exams or the self-assessment or anything, just drop them in the chat. I download the chat and then I'm able to talk to the certification team and get the correct answers for everyone. So, let me check the chat really quickly, make sure there's nothing. Okay. You did not get the slides from last week. All of the slides, I talked to the LMS, all of the slides are now in the LMS portal. So if you go back to session 1, you'll be able to see them. But when I am done with this, I'm just going to add the slides into the chat. Perfect. I see that they're there. Amazing. I can just add them into the chat for last week and then this week just to ensure that everyone has them. So that is the first thing. So thank you for bringing that up. And then all the slides should be in there for the rest of the course. I know some people wanted to print them out and stuff like that. So they are in there and they're able to do that. The next question we had was the pass rate. Is it okay? Thank you, Julie. I'm going to write that down. The next one was the passing rate. It is a 75% pass rate. So I wanted to make sure that that was told to everyone. See the next one. How soon can you retake the test if you do not pass, which we do not anticipate? You cannot take it within a 90-day period. So you do have to wait 3 months to retake the test. You can purchase it right away, right afterwards, but then you do, in order to schedule it, you do have to wait. You can take the exam 4 times in a 2-year period. And then the other questions we had was about the test centers. So I found I didn't see that you needed an authorization number. So I got the URL that I'll put in the chat of where to go to find a testing center near you. And then I also, just because of the authorization number, I was like, that sounds a little weird. I also added a help desk email and then also a phone number for you to call in case there's any issues. We do use a different company for this called PSI. AHA certification team is also able to help. So there's a couple different resources for you to use. I will put that in the chat to everyone now. And then I see another question. Competencies. So sweet. Thank you for adding the questions. We're just going to keep adding them. I will copy them and then we'll start the next session over just like this. But I don't want to take any more time away from the faculty and get you guys started with the content. So thank you guys so much for participating in this process with me.
Thank you, Tony. Hi, everybody. How was everyone's holiday week? Have a good week?
It was good.
Yes.
A little time with family, which is good. Yes. Saw some fireworks. Awesome. Anybody have any really cool shows that they saw? Anybody anywhere fancy? Mine was in my backyard, so not so fancy.
Great to be home though during some of those celebrations. Then it
was nice. There was no traffic, so it's fantastic. Some of the rain hit, right? Yeah. At the beach, that's cool. Yeah, that was cool. Nice. Very nice. All right, we are here to talk about our favorite topic as nurses, finance. Who loves finance? Yay!
Getting some shaking heads.
All of us, right? Yeah. Okay, so we're going to try to make this as interactive as possible. Please feel free. This is your time to talk through. We recognize that finance, typically for nursing, we hate finance, right? I hate finance. I'm teaching it. So we recognize that this is usually an area that people have a lot of questions for. Feel free to stop in the middle of it. Let's have this conversation. If you don't quite understand something, chances are 99% chance that somebody else doesn't understand it either. So no question is silly or dumb as we go through this. Again, this is your guys' time to ask that stuff. So please stop me as we go through. And with that, we're going to get started here. So as we were doing in the other ones, I'll just show you here again the competency. We are in the business skills and principles. It's broken out into the section of finances, what we're going to review next. And as we've done with all the other ones, we are going to start with a practice question for you guys. And we have a poll here, and you can see that there. So it's not the right poll, I don't think. Nope, sorry, Tony, it's not the right question. You're muted.
It's just like the generic one, the A, B, and C. Are you not seeing that?
I'm not seeing that, but it could have been me.
All right, so if the variable costs are best described as what cost, then use that poll that doesn't have the question and choose your answer to be A, B, C, or D. It just doesn't link exactly to the answers, I think is what Tony's telling us.
Yes. Okay, we're 52%. All right, I'll go ahead and end it.
All right, let's see what we got here. So most of the group went with B, change in direction relation to volume. There was a couple A and there was a couple C. So thank you for that. We'll go over the reasonings here. So the correct one is the majority of the group is that variable cost change in the direction relation to volume. And then we had a couple of the A, the variable cost change in direction to volume. So this is the exact opposite of the correct response, right? Because it says do not vary with volume. And it really, again, B is that it changes with the direction of volume. So be careful when you read these questions, when you read them real quick sometimes, that happens. So make sure that you do read what the question is asking to get the right answer there. And then C, change with quality. Again, variable costs are related to volume, and while quality may be impact on the cost, it's not included in the explanation of the variable of the cost. So that's another one of those, it's kind of correct, but not fully correct kind of those questions, right? So again, B is the answer, variable cost change in the direct relation to volume. And one more practice question here. Which of the following is the most effective way of a nurse manager can reduce direct nursing hours per patient day? Reduce the amount of approved staff vacation time, increase clerical and or nursing assistant coverage, analyze the need for ongoing patient sitter coverage, and seek approval for additional nursing resources.
There we go.
We're up 57. There we go. 60, getting up there. Couple more. All right, there we go. So we have a variety of answers for this one. So we're going to go through all of them. The majority of the group answered C, but the next one was 29 as well. So C is the correct answer. And the reason for that is you are analyzing the need for ongoing patient sitter coverage. So you are controlling and or decreasing patient sitter hours will have the greatest impact on the nursing worked hours per patient day, because since they are working within the department, they are counted in the hours. And if you can reduce what is working in the department, you can reduce those hours. So that is the reason for C. But let's go through all of the answers because again, we did have kind of a variety of all the answers answered there. So the reason that A is not the correct answer was reducing the amount of approved staff vacation time has no effect on the direct worked hours per patient day. It's there, it's in your budget, it's something that you need to put through, but it's not the direct care of that hours per patient day for the unit. For B, increasing the clerical and or nursing assistant coverage is going to do the opposite. It's actually going to increase your nursing hours per patient day because you have more staff that is hitting that cost center, which means it goes up. So it wouldn't be effective to reduce the direct hours. And then D, seek approval for additional nursing resources is a very similar answer to B. Seeking approval, again, increases those hours instead of decreasing the things to the unit. Does anybody have any questions on those two questions? Or why the answer was what it was? No? Okay, let's go to the next one then. So what do you need to know? There's a lot of stuff on here that we're going to go over in a little bit more detail, but the financial process, reimbursement models, healthcare economics and business models, managing a budget. So we'll talk a little bit about the budgets, monitoring those budgets, not only managing, but also monitoring, addressing the variances from a budget, and then the financial health. Next slide. All right. So has anyone ever heard of zero-based budgeting? Anybody do this kind of budgeting in their organization? Couple? There's multiple ways of doing a budget, right? And so some organizations do it different ways. Zero-based budgeting, again, we're going to go through some slides in a little bit more detail here. We're going to talk about cost benefit analysis. What is the difference between a capital and operating budget? And again, I'd love to hear from some of you from your own organizations because every organization has a different threshold. So we'll talk about that a little bit. And then monitoring your budget. Go ahead to the next one. I think we're going to go into zero-based here. Oh, a couple other skills here. Knowing the cost for recruitment. That's very important in your organization. There are differences. There's nationally rated cost for recruitment that gets updated every single year based on staffing and where we are nationally. But there's also local, your organization may have the cost themselves. Or again, you can go off those national standards as well. Does anybody happen to know what the cost of recruitment nationally is today? Any guesses?
$60,000. Oh, look, they got
Well,
much
there's some guesses.
Yeah.
80, 85, 75, 50. Yeah, 40. 65. So the national standard actually is $56,000 per nurse. Now, it also depends on, that is an average, right? It depends on the specialty, right? So if you had a specialty nurse, that may be a little bit more. A nurse manager, obviously there's more for that. So that's a higher cost as well. I think don't quote me on this, but I think the last standard I saw for a nurse manager was like 125,000. So obviously that goes up a little bit more comparatively to the staff, but $56,000. So a lot of people use this as a way to, if your turnover goes down 1%, there is some ROI. There's some cost savings to that, right? So a lot of people use that number to show and prove in the finance world how we can get some positions and why we need them and what that looks like. So we'll talk a little bit about that. Your principles of staffing, hours per patient day for inpatient is there's different national benchmarks for hours per patient day, but that's inpatient. There's also like an emergency department's going to use different counting for that, right? So instead of hours per patient day, they're going to use probably patient visits, right? And you're going to have a different hours that you would get based on your patient visits. OR has a different kind of structure for that as well. So depending upon your specialty and where you're at for nursing, that will adjust. Most of the stuff that we're going to talk about, though, is that hours per patient day on the inpatient unit. And then the elements of your labor budget, what goes into that, and marketing as well. And are we getting training and onboarding for nurse managers? We are not very good at that anywhere, are we? It's kind of like the tap, hey, this position's been open for 6 months, here you go. All right, so what is the nurse manager's role in a budget? Have any of you done a budget as a nurse manager? Have you worked through that yet? We had variety of experience, if I recall correctly, right? So some have been doing it for quite a bit with it, some experience, some are kind of new to it. Yeah, some angry faces. Do we like to do the budget? Yeah, right. So what is the nurse manager's role in that? And again, this varies hospital by hospital. I've seen it go multiple different ways where honestly, when I started in nursing, we did a lot with the budget, a lot. And I sat down and had hours and hours and hours with my finance person who taught me a lot. And then as things have changed and workforce have changed and through COVID, then I've gone to the other extreme where like the budget was just handed to me and there was no clinical knowledge and thought process. There was a bunch of numbers behind it. So it is very, very important to meet in the middle. Obviously, we are nurses and we are clinical, and finance is not our expertise, and that is their expertise. But we have an active role in the budget, and you can be scared of it and unsure of it, or you can really lean into it, and that will make you a better leader, right? On really leaning into the things that, I'm not quite sure what this is. I have other resources and other people to rely on, and finance should be number one person in your back pocket that you can call and talk through some things. But what is the responsibility of the nurse manager? Analyzing those costs and those benefits, right? You know what the kind of equipment you're going to need on your unit. You know what staffing you're going to need on your unit. The things that are going to hit, how much paper that you need for your unit, and the printer, right? Like all that stuff that your unit uses goes into that budget. On top of the labor side of managing that productivity and what that looks like, and that visit count that you have for a patient, right? So productivity is based on the amount of patients that you have. And I'm sure most of us have staffing grids if we're on the inpatient unit, right? When you have 5 patients, you have this many nurses. When you have 25 patients, you have this many nurses, this many support staff. All of that affects the productivity. And why the finance looks at that used to be, they like that happy place to be about 95 to 105% productive. If you're lower than the 95% productive, that means that you have too much staff, essentially, right? You have too many people hitting that cost center for the amount of hours that they were expecting to hit that cost center. If you have a productivity of 120, that is the opposite. It means that you don't have enough staff. So how can we rearrange some of that staff to get them some more resources, because that's what that's showing. You need more resources in that department. Nowadays, again, different organizations are different. They really they're pretty close to that 100% where they like you to kind of be at all the time. But productivity is stagnant, right? I mean, as patient volume changes second by second, so does your productivity. So for these variable units, you really have to kind of keep a constant eye on it. And then monitoring performance against the budget. How many of you have to put in monthly into like a strategized program when you're not hitting your budget somehow or another? How many of you have to explain it? Yeah, a couple things, right? And obviously, as the manager of the unit, you are responsible for explaining that budget, even when things happen into that budget that you may not know, but that means you need to get into the weeds to really figure out, okay, why is this one not what we expected it to be? And there's probably perfectly good explanations for it. We had higher volumes than we expected. We had lower volumes than we expected. We had, this extra cost that came out that we weren't expecting. We had to train staff to do this new thing over here that wasn't part of the budget, right? The budget is only once a year, and you are operating on a monthly, daily basis. And so being able to explain those variances is very much the role of the responsibility of the nurse manager too. Your supply management, that budget justification, and capital we'll get to here in a second too. All right, so the purpose and the function of a budget. It is a guideline and a mile marker for financial performance, right? A budget is done, it's done once a year. It's a process that takes much longer than once a year to be able to do. It's over several months of a process, but it's only one point in time. And it is essentially our best guess, right? They look at some volumes, they look at, history, they look at what they think is coming down the pike. So being able to explain why you're off from that budget, because at one point in time we thought this, but we were wrong here, or we had more volume than we expected. And here's that again, that goes back to that explaining the budget and the variance. Being able to forecast for those resources requirements. So inpatient unit, typically we know that, through January and March, we're going to have a flu season and we typically have more patients. But then in the summer months, we typically have a little less patients and then we go back up again, right? So you kind of have this U and forecasting and budgeting that way so that you have more support at the beginning when you know that you're going to need it based on history, and at the end, but not so much in the middle. And initiating that planning process and coordinating and communicating among services. So cannot stress enough how much communication is important in the nurse manager role when it comes to finance. And again, you have the clinical knowledge. So you know why the resources are being used and what that accounts for, and taking that finance partner to be able to understand their role too, to meet in the middle. So what are some of the calculations that we do? And we're going to go through some of these. FTEs, which means full-time equivalents, hours or unit of service, ADC, which is average daily census, your patient days, and then your salary dollars. Budget justifications in that variance report. So again, I asked everyone how many of you have to write a variance report, right? Most all of us have to write kind of a variance report for a unit that we are responsible for. But it includes all those elements of the budget, right? When I first became a manager, I was in charge of the emergency department, and the providers that we paid in the emergency department were a part of my overall budget. Nothing that I controlled whatsoever, but I still had to understand that and be able to speak to that and know the variance of things with that too. So other things anything that's hitting that unit is in that budget. Analyze deviations from the expectations. Again, one point in time, what happened differently? What does that look like? And lay out those steps needed to address, right? When we're addressing that on a monthly basis, we're also saying, we didn't hit this mark. This is why. This is what we're going to do to hit the mark next month, right? We're putting in those the processes to fix it. So zero-based budgeting, what this is, and I'm curious, does anybody actually use zero-based budgeting today? A couple people? I can't really see the hands. I can see Andrea. So couple hands. Yeah. So what is zero-based budgeting? It is driven line by line approvals without comparing last year. So essentially you take your run rate out the door and you don't look at it, and you go off of what you expect this year would be, or this coming year and the budget season is going to be, right? It is a little bit more complex. It depends on which organization you are a part of for how they do their budgeting and why. And you have to go again line by line to go, yes, I need this. Yes, we're going to use this, or no, that was something that we don't need anymore, and I'm not going to budget for that at all. So it gets wiped away, where you really have to look line by line by line to say, yes, we're gonna need all of this stuff that we have in here. It's linked to strategic objectives and planning. So it's planning, the next 3 years, we know that we're going to have here, or we're getting a new provider in this space. So I know that that's going to add more patient volume, which means I need to account for that volume and the staff and all the resources and the supplies that go along with that. So that is that strategic objective and planning. And that requires that systematic review of the functions of the services. Again, it's not just there because we've always used it. You have to really evaluate, yes, this is something we are going to continue to use. This is the right staffing that we're going to continue to use. This is the right providers. This is the right supplies, all of that stuff year after year. So a cost benefit analysis. Has anyone had to do this? Anyone had to come up with what an ROI is and a capital plan, or not a capital plan, but they want a piece of equipment or something, right? Yeah, a couple people have experience with this, right? So you have a cost benefit analysis is really looking at what is a project cost over a defined period of time. What are the benefits and what is it going to cost, right? So the ROI, you'll hear that term a lot, ROI, which is return on investment. If we put this money in to get this thing that we want, then how long is it going to take to earn that back in with that, right? So that is that return on the investment. How long is it going to take me to get the money I put in today back? Sometimes organizations do that on a yearly basis. Some people do that on a 5-year basis. Some people will even do that on a 10-year basis, right? Before they will determine. As healthcare is changing, that is getting shorter and shorter and shorter period of time, right? And so you really, from the nursing aspect, need to be able to speak to my return on investment of these 2 extra staff that I really feel like my team needs is going to be XYZ, right? Because we have this volume, we have that. Being able to speak that language will help you get what you need on your unit a lot quicker. And then also determining what expenses will be incurred in implementing that change. What does that look like, right? There's going to be savings. I mentioned a little bit of the turnover rate, right? Using that $56,000 of like, I know I can, if we put this engagement piece in, I'm going to retain 1% of my staff, which is this ROI on this initiative to be able to save this. So it'll take me this long to make up this money.
I think the other thing, Ashley, here is to think about like IT support with like new equipment, construction changes. Sometimes if you're adding something, that part needs to be included in it, but something to think about when you're trying to advocate for like capital equipment or something like that.
Yeah, and most organizations have what they'll call a template for this too, right? That kind of helps you through that because we don't do it every day, right? For you to be able to hit those things, like to think about as well. If you're lucky enough to have a strategy department, they do this all day long. They are a huge resource of a benefit to be able to help you with those kind of things too. But essentially, it is that big picture, everything that's going to hit all in one, right? Thinking that bigger picture. So capital versus operational budgets. I'm curious if any of you know what your capital threshold is. What makes it a capital expense in your organization compared to an operational expense? Ashley, go ahead. I see your hand up.
So our capital threshold here at my hospital is $7,000, and how we define the difference between operational and capital is I work in imaging. So if it is anything that is connected to an already pre-existing machine, such as maintenance, replacement of parts, anything like that, that is operational. Whereas capital is like the replacement of the equipment itself.
Great examples. Yes, I'm seeing a lot in the chat here, mostly 5,000, right? That's what I'm familiar with too. That's kind of what it's been. How many of you have bought a bed under $5,000? Not many, right? Like you can maybe get it to 8. How many of you have been very strategic and had them write it up in 3 different quotes so that it can be under a capital to get what you need, right? Sometimes we do a little bit of things that we probably shouldn't do to be able to get what we need. But the difference really between the capital and the operational budget. Operational budget applies to all functions required to deliver the product or that service, right? It is the day-to-day actions on that unit. It is the supplies, the things that you're going to need right then and there to take care of those patients, the staffing, that kind of stuff, right? That capital budget applies to those larger purchases that we were talking about and those larger defined projects, right? Where we want to revamp 4 rooms and we're going to do XYZ with it, right? That may require some capital planning of your organization as opposed to a budget. Typically, operational budgets are controlled at a manager level, and a capital budget is controlled at an entity or a system level, right? So there's different levels of approval for those things as well once you get to certain levels. And you can see the variety. Some are 10, some are a little bit more, some are 5. So it varies entity by entity where you're at. And again, they have a predefined cost minimum and a lifespan stuff too. Any questions on capital versus operational? Okay. We are 30 minutes in. Are we hanging in there to the finance ladies and gentlemen? I say mostly ladies on my page. Sorry for gentlemen that are on here. Are we good? We're good. Okay. So monitoring your budget, definitely something that is a huge responsibility of our nurse manager, right? Again, it may be things that you do not have any control that are hitting your budget, and you need to be able to see that and to understand that and to be able to explain that. So a lot of that is asking a lot of whys and a lot of questions of people, right? What does this look like? What is this line hitting here? I didn't know that that was coming. Can you explain that to me? So that you can speak to it for your unit, and you can also work to budget for it for the next year. If it's going to be something that's reoccurring, what does that look like? So identifying the source and that frequency of the data, integrating the data, and looking at your productivity, your staffing. Again, enterprises have it different by some set some expectations for their leaders of when they expect you to look at the data, when they expect you to put in things for it, and others do not. So it depends on kind of the culture and where you're at there. At a minimum, again, my opinion, I think as a nurse manager, like at least a monthly basis, we should be looking at that stuff. But truly, for you to really know the details and the weeds, it's at least a weekly, if not a daily kind of thing that you are monitoring a lot. But again, organization by organization, that changes, and unit by unit it changes too. But using the incoming data to drive your actions, your changes, just like when we were talking about the quality and the patient experience data, right? How do we do that? And what do we pull from that to be able to make some changes with our staff? Exact same thing when we're talking about the finance aspect of it, right? It is a different data point, but how frequently you are looking at it depends on the area that you're looking at too. And then how do you communicate with your key stakeholders about your needs and about the variances and about what's happening on your unit? So we talked about recruitment, right? Know your cost for recruitment, that backfilling vacant positions, the premium labor staff that it cost, right? So that $56,000 that I gave you was just the recruitment side of it, right? Like, so now I have to fill with some agency or some overtime or, my internal agency, which is an extra cost of for organizations. So how much does that cost? For how long does it take on an average to refill a position? And there are some national benchmarks on how long that takes too. Again, varies by specialty. This is going to be off the top of my head, so it could be wrong too. But I think the last thing I saw was like 75 to 85 days that it took from the time you posted direct to the time that you actually got a nurse on the floor, right? So being able to plan for that 75 to 85 days average. Again, your unit might be different. Your specialty may be even longer than that. Sometimes, OR staff's hard to find. Cath lab staff's hard to find, right? So that might take a little bit longer that you have to be able to plan for the backfilling of that at a premium labor cost. Orientation costs we mentioned. We mentioned it for nurse managers that we don't really have a whole lot of that, but we do know that our frontline staff, right? Again, usually have a structured weather approach depending upon the unit, how much experience they have, how long they're going to be in orientation, and what that means. And then reduction in your preceptor productivity, right? How long your preceptors are going to have extra things to do here on top of precepting different staff. So being able to account for all of that too. And your expense for marketing positions. And this is not something that we really have a whole lot of access to if we don't ask. And you may have to kind of hunt it down a little bit depending upon your organization too for what that overall cost is organization by organization. So good old staffing, principles of some staffing here, right? So impact of staffing on the budget and the performance. Your patient census is high, you need more staff, you budgeted for a lower patient census, it's going to affect a variance, right? And you're going to have to be able to explain why that is. And that using that metric of that productivity helps with that because your productivity faces on the volume. And so you can say, we are over budget in our staffing because we had higher volumes, but our productivity is 99%. And that means that we're using our staff effectively. Even though we're over budget. So being able to explain why. Professional and community standards related to the staffing. There's different national benchmarks that are out there that can kind of set the worked hours per patient day depending upon the unit that you have and the type of unit that you have. Again, that's what it's talking about for professional and community standards. And then linking that staffing level and outcomes. And this is another factor that you really could get into the weeds a little bit to prove an ROI, right? I need another nurse because XYZ, it's going to help with quality, and those are the outcomes here. It's going to help me with this. And so on the long run, this savings here, if we don't have a CODI, which causes, cost our organization XYZ, by having this extra staff, I can prove that ROI, right? So again, it's the storytelling of what that looks like, but knowing all of those factors that go into that. And that's not, we call those soft costs. So that's not an easy thing to go to your finance people and say, I need another nurse because it's going to help me with quality, right? But you really need to be able to speak that language to them to say, here's the things that this does. Here's the national benchmarks, and this is what this is telling me. Here's our fall rate, right? All of us, I'm sure, are struggling with falls in one way or the other. None of us have really figured that out greatly yet. But if you give me extra staff, I'm going to save on falls, which is this X rate, here. Again, it's a story to be able to tell, to push what you need for your team. And then the staffing mix. So your productivity looks at the amount of bodies and people that you have. Your FTEs look at the amount of bodies and the people that you have. It doesn't necessarily look at the skill mix, right? Of the difference of the fact that there's an RN here, and then there's an LPN here, and then there's an aide here. Worked hours per patient day is who hits your unit. It doesn't care who that is, but your quality and your outcomes care who that is, right? So again, being able to explain the differences there and what that means, and the roles in the FTEs. So the labor budget. So again, the salary expense, the variations among the roles. You have higher cost salaries, whether that's, again, between an RN or an aide, different cost points there, right? Different averages of their wages and what that looks like. So being able to understand how many RNs your unit needs, how many LPNs your unit needs, how many managers your unit needs, how many, secretaries that your unit needs. Each one of those is a different average that adds up into that salary expense. FTEs, and then the productive time versus the non-productive time. And again, every entity or organization somewhat has a little variation on what that looks like, but essentially productive time is working patient-facing at a bedside, here. Non-productive time is that vacation time that we talked about, right? We have to budget for it because everyone still gets vacation, thankfully, hopefully. They're taking good vacations and getting rest. But that's that non-productive time versus that worked time. And then premium labor use. So premium labor is a generalized term that just basically says anybody that you're paying over their regular wage, consider it to be premium labor, right? So agency cost or higher cost, that's a premium labor. Overtime cost, sometimes we give out bonus structures. You pick up this extra shift, I'll give you an extra $10 here, right? That's all called a premium labor use as well. And then what's controllable versus a non-controllable cost? Any questions on the labor budget?
I have a question. So the productive time versus non-productive time versus worked non-productive time. Sorry, can you review that one more time?
Yeah, so the productive time is the time that is actually on the unit being worked, right? So I clock in today at 7 o'clock, I clock out at 7 p.m. That is my productive. I am on the unit, I am working. The non-productive time is time that we still have to account for, but I'm not actually working productively in front of patients on the unit, right? I'm taking vacation. You still are paying me. It's still a salary expense that's coming out of that budget. But that's considered a non-productive time. And then your worked non-productive time may be, again, a little bit varied, but that may be like I'm in orientation time, right? I am on the floor. I am taking a class. You are paying me. I am at work, but I am not in front of that patient, affecting that productivity of that department in front of a patient. So that's the worked non-productive time.
Ashley, would that also include like meeting times or education time?
Yep. Because again, they're at work, but they're not in front of patients, right? So you're still paying them. And again, different entities may have a little bit different, unions may have a little bit different what they consider non-productive work time versus productive time, what that looks like. But in the general sense, productive time is I am in front of a patient, I am working, I am there. Non-productive time is I am not in front of a patient. Modified RN is considered worked non-productive time. What do you mean by a modified RN?
When an RN, like at my work, they have a limit that they cannot really do a bedside because they have injury or something.
Oh, like an injury or
Light
something? Yeah.
duty, like a light
Yeah.
duty or alternative
Yep.
duty. Okay.
Yeah. So that's considered work non-productive time because they're not taking care of a patient. They're doing some kind of a clerical or something.
Depending upon what you have them do, right? So if they are sitting on your unit and they are taking the role of a secretary because they have a lifting thing, but they can do the secretary work, right?
Yes.
That's still productive time because it's patient facing time. But if you have them off into a corner and they're reviewing quality charts and they're, not
like
something you would have it do, then that would be the non-productive time.
like audit charts and
Yep.
stuff. Okay. Thank you.
Yep. Share an example of a controllable and a non-controllable cost, right? So controllable costs are things like your supplies, right? Those are a controllable cost. Labor is a controllable cost. A non-controllable cost is probably a contract that you have on your department that, say you have virtual nursing and the IT equipment cost X to use per patient bed, right? That's going to be a non-controllable cost. It's the same thing all the time.
For facilities charges,
Yeah.
phone charges, like telephone or something like that you have to pay for something, you don't really have that's helpful.
And I see that, Michelle, that's nice. Yeah, your organization modified RN budget comes from a different bucket because then it doesn't hit your unit productivity, right? So again, different organizations do a little bit differently of where we put them. But as a nurse manager, you should know that, right? You should know what your organization does and where they classify them so that you know what's actually hitting your unit because it is going to vary.
There's one other example I think of a non-controllable cost, and that was interpreter services. I think that's a good example of something like
that's
that.
a good example. Okay. All right, good questions.
I'm sorry, Andrea, you said interpreter services was a non-control. Okay, thank you.
Can be example of that, Eve. So you'd have to explain it if it's a variance to what they budgeted for you based on your run rate, for instance. But if you had several patients that needed the services longer term, that would be something you could easily talk to.
So a sitter is going to be what we consider a controllable cost, right? Because you are controlling the fact whether you have the sitters or you don't have the sitters. Now, patient volume, it might be that aspect of like, well, wait, I really can't determine this because of these patients, right? But it is, go back to that example that we used, it is considered a controllable cost. All right, let's go to the next one. So marketing, purpose, image. Do any of you deal with marketing or have communications with your marketing team, or have any of you done, flyers for your units to help recruit? A couple people. Yeah, all that runs into a marketing, right? And typically there's, organizations have a marketing department, which doesn't necessarily normally ever sit in a nursing department, right? But you need to be able to collaborate and work with them because they do help you on your unit to be able to explain things in the way that you need it for your people. So the 4 P's of marketing, this is the caveat star that I would kind of write down, right? What are the things about marketing that I need to know? Understand these 4 P's of marketing and know what they are. So product, price, place, and promotion. Star that, or that may be a question that would possibly come up for you, right? Again, all the stuff of the marketing piece of it, that's the most important to know. What are those 4 P's? Product, price, place, and promotion. Really valuable in the outpatient setting. Yep. When you're trying to grow that services and you're trying to pull people in, right? Yep. or again, I used it for the inpatient on the recruitment side, right? Like, what does my unit do, and how do I explain that to staff, and how, my product is my unit, my price, and my place, and that promotion, and how am I getting that out to? How am I encouraging that people see this, right? So thinking through those things for marketing, image building, public relations, for marketing. Next slide. All right, strategic management. So high reliability concepts, sources of that evidence-based data, the objectives that align to a strategic mission, contracts and service agreements are some of the things that fall into this. Aligning department goals with your organization goals, that strategy, that role of technology on care, the clinical information, and the financial outcomes, that bigger picture, putting it all together, and then relevant metrics. We can go ahead to the next slide. Okay, so we have about 10 minutes here. We're gonna do, and we have a little bit longer because if we go into that other section, that's probably okay too. So we'll do this a little bit longer. But what we'd like to do with you guys, since we are on a Zoom, we're gonna give you kind of individual time to kind of work through a little bit of the math behind some of these things, right? And I think you can go ahead and go to the next slide because it's gonna say some of the questions here. So financial management, this is our scenario essentially, right? So you are preparing to open a brand new 24-bed med-surg unit. Beyond the type of patients that will be cared for on this unit, you need to know the following here, right? The annual patient days of the first year is going to be 5,475. The direct care staff that will be comprised of RNs and CNAs. There's a skill breakdown of 70% RNs and 30% of the CNAs. So that staffing matrix calls for 12-hour shifts, which means on day shift, you're going to have 4 RNs and 1 CNA. And on nights, you're going to have 3 RNs and 1 CNA. So this is our scenario, and then we're going to have a couple questions to try and help kind of build this budget a little bit. So we'll give you a little bit of time to work through this, and then we will go over as a group kind of question by question to how we got to some of the answers. So please calculate, one, the average daily census, right? So remember that, let's scenario back up. It was 5,000. There you go. 5,475 annual patient days. So we're going to want you to do 4 things. Calculate the average daily census. Calculate the number of FTEs that must be filled in order to provide that direct care over a year period. And remember, it was 4 for 12 hours, 4 RNs and 1 CNA. And then for the other 12 hours, it was 3 RNs and 1 CNA. Number 3 is the number of FTEs that will be needed if the staff worked 8-hour shifts instead of 12. So account for the fact of duplicate that day shift volume, that 4 RNs and 1 CNA, put that onto the afternoon shift now, 4 RNs, 1 CNA, and then the 11P to 7A would be our 3 RNs and 1 CNA. And then what is the worked hours and the unit of service that will be used? So we will give you guys individually, again, some times to just kind of think through. And if you don't know the answer to the question or how to get there, that's okay, right? That's what we're going to talk through as a group when we go through there. But Andrea, what do you think of our time-wise that we give them to work through?
Like 10 minutes,
10
maybe
minutes?
get through at least the first 2 questions, and maybe we can do the 3 together if we need to.
Yeah, remind me what UOS means. That's unit of service. So worked hours per patient day or unit of service. Again, it depends on what kind of department that you're in for what they consider it to be. So unit of service could be inpatient, hours per patient day, ED, patient volume, OR visits, right? Like, so it depends on what it is. So it means unit of service.
Tony, is it possible for you to put in a PDF of the scenario in our chat for them?
Yeah.
Thank you. That way I can keep the questions up.
And the question is, what are the hours? Yeah, that is what the question is. That's what they want you to figure out. What are the hours? Oh, sorry. Yeah, it's 5,475.
75.
Sorry.
Are you finding the PDF, Tony?
Yeah, so just a slide before this, correct?
Yeah, this one
Yeah,
right here.
that one.
Yeah.
Yeah, I just needed to download it as a PDF
Oh,
and
I'm so sorry.
extract it. No, it's no biggie. Yeah. All right. Page.
All right. Does anybody want to brave the first question of average daily census and how we calculate that? Any volunteers?
15. We divide
15. You are correct. How did you come up with that?
we divide that 5,475 for 365 days.
Perfect. You can go ahead and go to the next slide, Andrea. I'm just going to say this for us. There you go. Awesome. You hit that right on nail on the head. So perfect job there. Nicely done. All right. So the next one then, anybody come up with the total FTEs?
Thirty-one 59.
How many do they need? 18.95. Ashley, how'd you come up with that?
So, I divided direct patient care staff by the shift length
Mhm.
and then got my hours per day and then hours per day times 365. And that got me my hours per year.
Yep.
And then I got the hours per year and I divided it by a full-time equivalent of 2080. And I
Yep.
got 18.95.
Perfect. Nicely done. Look, you could have built this slide for us. Very nice. There are, and Andrea and I were talking about this, there are different ways of doing this a little bit. You certainly hit it here. Like we're all kind of taught a little bit different depending upon the organization. So nicely done, explains it really well. And you nailed that head there a little bit too. So good job. All right, so let's about the next one is to calculate the FTEs if we were in 8-hour shifts. What did we come up with there?
1965.
How did we come up with that?
Same principle like before, but this time you said that to duplicate the morning shift.
Yep.
So we came out with 14 staff times 8 hours equal 112, and you multiply that for 365 days, and that you divide it for 2,080, so it come out to 1965.
Very nice. Good job, Anna. Can you go back to the last slide so we can write down the calculations? We can certainly do that for you. And you guys are going to get copies of these slides too, but we can certainly do that for you here. We'll give you just a second here to write down those calculations, and then we'll go back to the next slide so you can see the differences between the shifts, right? So, the good old days of the 8 hours versus the 12 hours, the budget, what that looked like, right? You can see the FTE difference between a 12-hour shift and an 8-hour shift and being able to account for that.
You guys ready for me to go to the next slide?
Sorry, where is the 2080 hours coming from on that bottom number? I'm trying to follow along.
So that's
9,000. Oh, sorry, go ahead.
For the year, right? So that's the hours. So they got the hours for the year divided by the 2080, which is the FTE.
The definition of an FTE, Christy, is 2080 hours.
Here.
Can you explain that a little bit? Because I don't think I understand that.
So
Go ahead.
Go ahead, Andrea.
No, that's okay. So full-time equivalent, which is an FTE, is defined about how many hours annually that person would work. And that's the term we use, FTE.
Got it. Okay.
Now,
So-
some folks get that confused a little bit with things like 0.9, 0.6, or and that's a position control, which is the portion of the 40 hours that team member physically works in your unit. But for the sake of calculations, we use 40 hours as our target, and then 40 hours per week in a year is 2,080 hours.
Thank you.
Would you add anything else, Ashley?
Just that then is what's considered a 1.0 FTE, right? That is that 40 hours is the 1.0 FTE. Now, if they were working 36, which most nurses do, right, that is a 0.9 FTE, and it's a different hour calculation. But for this one, they look at the year. When you're talking about the budget, they look at a year. So they look at it as a 1.0 FTE. Correct. Yeah. So if there's 36 hours, 12-hour shifts would be 36 hours. It'd be a 0.9 FTE instead. Yep. Any other questions? This is confusing, so feel free to ask questions. It's okay.
That's why we're here. That's
Yeah.
like the part that we really want to make sure you get really well, feels comfortable with it. I'm just going to go to the next slide to show those calculations again for an 8-hour shift to make sure everyone understands this.
I have a question, just not being a manager who has managed the budget hours, is there any way you guys can explain how did we come up with 112 hours a day?
Yeah, that's a great question. So at the very beginning of the scenario, we gave you how much staff that you were going to have, right? Which is a little bit backwards because sometimes that you get the number and then you got to figure out how many staff you can have with it, right? But the way that we're doing it in this scenario is we're giving you, here's your staffing grid essentially, right? So your 4 RNs and your 1 CNA. So that's 5 staff members. Then for that particular one with the 14, we also said, now we're going to look at 8-hour shifts. So we're going to do that on the second shift as well, which is another 5 people. So now we're at 10. And then on nights, you have the additional 4 people. So now we have 14 total staff that are all working 8 hours per day. So if you go back to that slide, one more. There you go. That's 14 staff members, right? 4 during the day, RNs plus a CNA. So 5 total during the day, 5 total in the afternoon, and 4 total at night equals that 14 staff, all working that 8-hour shifts, which gives you that 112 hours per day. That's how much hours each of those staff members is working in one day together.
Thank you.
Mm-hmm. Good question. And then, yeah, you times that by, okay, there's 365 days in the year, and that's where you get your 40,000.
And then I just wanted to clarify, so the average daily census isn't calculated into this, right? We're just calculating this based on the staffing matrix.
Correct.
Okay, thank you.
Any other questions on this before we go to the next calculation and see how we did on the next one? Okay.
All right, so calculate the worked hours per patient unit of service that will be used for the 12-hour shifts. We had that hours of 39,462 hours, right? Going back to that other one, we figured that out earlier. Now we're going to divide it by our yearly census, which is the 5,475, to come up with the patient days. So our unit of service is 7.2 for the 12-hour shifts. When we have the 8-hour shifts, you're going to take that 40,880 hours divided by that 5,475, and then you come up with 7.47 units of service needed for 8-hour shifts. So again, the point of this is to be able to see there is differences in the amount of time that you have the staff and what that looks like, because you need more staff for an 8-hour shift. Anybody get those correct? Couple people? This one a little bit more confusing than the others?
I personally didn't get 2 and 3 right, so I didn't attempt this one, but can you just explain, please, sorry to dominate the questions, just the definition of worked hours unit of service. So what is this? So like, for example, in the 12-hour shift, the 7.2, what is that?
Worked hours per unit of service means how many hours does it take to take care of that patient, essentially, right? So for every patient I have on the unit, I'm going to get 7.2 worked hours per patient unit for the day. So that means within 24 hours of time, I'm going to be in with that patient, whether that's nursing or my aide or whoever's hitting my cost center, 7 hours out of that day, 7.2 hours out of that day, I'm going to be with that patient. That's what the benchmarking is telling us, right? Now you're going to have so if you have 2 patients, that's 14 hours. Which means, right, 14 hours is not 24 hours in a day, right? So if you have 2 staff members for 2 patients, your productivity is going to be way low because you have too many hours based upon what it says that you should have for those 2 patients, right? So most units don't obviously have 2. They have more, and this is for like a med surg unit. So different worked hours per patient day. If you are on, say, an ICU, higher level of care, you're going to benchmark and get more unit of service per patient. So more bedside hours per patient. Typically, it's around 17 to 19, depending on what kind of ICU that you have, right? So you can see the difference there. That means different staff because we have different staffing ratios because it requires more time to be in the room with a more complex patient, right? So that 7.2 is determining how many hours in a 24-hour day that you're going to be in a patient's room. And why I said it's a little bit backwards the way that we're doing it here was because most places now do benchmarking, right? Where they say, okay, you are a med surg unit, you have telemetry, you have these resources on here. The average across the country is 9.2 hours for this unit. Now you need to figure out the staffing that fits into that. And what that looks like, right? So because they're already giving you the unit of service that you're going to get for your department. But when you're building your budget and you know that you have the staffing grid, that's what we did, right? We took it from the staffing grid and we built, these are the amount of unit per service that I need on this unit.
Yeah, so I have the same question as Raj. Is this the same as HPPD? What's the difference between worked hours unit of same thing?
Yeah.
Okay.
So our hours per patient day is an inpatient term, right? So that, because a patient day for an inpatient can be dependent upon the unit. I mean, it could be 4 days, right? It could be 3 days. It could be 7 days, right? Like, so per patient day, that was where we gave you that number of 5,475 patient days to determine. We already gave that to you. But say you're in a different unit and you're in the emergency department, people don't stay for, hopefully people don't stay for days in the emergency department, right? They stay for hours. So you get it based on an emergency department is a ticker of 1. And for every 1 patient you have in the ED, we expect them to be here for this many hours. And typically it's around like a two hour thing. So it is a different unit of service for that level of care. An OR has a different unit of service based upon how many procedures and what you're doing in the OR for that patient. So depending upon your unit, that's where the differences of hours per patient day or unit of service comes into. Essentially on the inpatient, your hours per patient day is a unit of service, right? So unit of service is kind of that universal term that could be used wherever you're at. Hours of patient day is very inpatient specific. Does that help? Does that make sense?
Yes. Oh my gosh. Thank you so much.
Yeah, you're welcome. And then who typically provides that data for the department? The unit of patient services? So it's usually a finance term. They get it from, again, benchmarking. My organization uses Vizient. The organization I was with previously uses Premier. So again, different national benchmark standards for what unit. And then you actually have to go through and determine, because every unit in every hospital is slightly different, right? But they have to generalize them enough that they put you into a category based upon the types of patients that you have on that unit. And that's how many hours that you get nationally benchmarked. Or you can see, this is what they call the 25th percentile. If you'll hear that term a lot, like this is the 25th percentile staffing unit that's given. This is the 50th percentile staffing unit that's given. And this is the 75th percentile. Well, 75th means that you have more staff than, most other people. So a lot of organizations, as we're trying to be more efficient, want you to be at that lower level of units for service. So it's a lot of times it's provided for you ahead of time because they're trying to benchmark it. But again, this process is for you to start from that zero-based budgeting so that you understand how that number is determined and what that looks like. Yeah, we get ours from the finance department. That's usually where it comes from. As an executive, I'm a chief nurse executive, so I work with finance to go like, yeah, this is not the right category, or no, we're going to hit the 25th percentile, or they're at the 50th percentile. There's no way in the next year budget season that I can put them in the 25th percentile. That's not realistic, right? So like I work hand in hand when we determine those, but at a nurse manager level, typically it's kind of given to you guys. Cath lab unit of service per patient, per procedure per day. Yeah.
Procedure per day. Yeah.
Depending upon where the patients are at, it's a little bit different. Yep. All great questions. Any other questions? In a question like this, would it be presented like you guys did on the test? Andrea, do you know the answer to that question?
It would be done as a scenario, maybe with just a couple of sentences and then multiple choice answers. So you wouldn't have as many steps as this particular scenario showed you, but it could be the first one where it asks you to calculate the ADC, and your answer would be A, this number, B, this number, C, this number, D, this number. So that's what I have seen on the exam. So that helps a little bit.
And did you say this is an example of that zero-based budgeting? Yeah, because remember that zero-based means you start from scratch, right? Which is essentially what we're teaching you guys how to do. You start from scratch. You know, I have this many team members. This is how many unit of services that I need for my department. So yes, it's an example of that.
You cannot bring a calculator during the test to answer your question, Jennifer, but you can use the one that's built into the computer at the testing site that you attend. And if you do that if you choose to do your test, I believe at home, I don't know if you can here or proctored, there may be other restrictions. You'd have to see what the candidate handbook says about that, or the testing center requirements. But if you're going to a testing center, use the computer that's the calculator built into the computer, and that's the only thing you're allowed to bring in. They're very strict about that. Okay. It could be based on the testing center, Jerry, so that you have to follow those very strict guidelines, and they may vary from testing center to testing center or wherever you're getting your exam done. Okay. All right, so concludes our finance. Ashley, you want to add anything else to that section?
No, I don't think so. But I mean, if you guys certainly have questions, you go and you review some of the slides, holler at us, let us know. We're happy to walk through. We're nurses. We don't like finance. So that is normal. That is typical to not quite understand this. I would encourage you all to lean into it and practice a little bit and work through some of those examples and look at your own unit and take it from that zero based upon your own staffing grid that you have, right? And see what you come out with what your budget is compared to, and do a little bit of practice there to get a little bit more comfortable with that.
So Jennifer, you asked about more scenario practice. So we do have the ability at the end on session 5 to potentially do some more calculations. We do have a couple other scenarios built. We can go through that last session if you'd like to do that. We can make sure we do that if that's a mark for you guys. And then let's see. Oh, and then Tony put in more specific instructions about use of calculators for us from the information. Your finance person should be your best friend. I agree with that.
Yep, totally. I'm new to my organization and he was my first meeting. So that, yes, they are your best friends. Absolutely. And can you explain the purpose of the unit of service? So the unit of service goes back to somewhat of a productivity measure, right? It is a finance term for how much every patient or hour, again, depending upon how it's kind of every unit of service, whatever that means, whether that's hours or that's patient days or whatever that is for your department, how much staff that requires to be able to do that. So it is a staffing term for how much you would need, the purpose of the unit of service. And again, it's different unit by unit, and even inpatient is different, right? Because it doesn't require the same level of care on a med surge that it does from an ICU. So it's the hours that you are with a patient.
Does that mean like how many people you would need for that day?
It could, right? So, okay, so if you're here, your 12-hour shifts, you need 7.2, but that means that you have to take your at what your typical average census for your unit is to be able to determine your staffing grid. So it helps you determine how much staff I can have and still be productive when I know this, because I typically have 15 patients on my unit. So 15 times 7.2 is that's the amount of staff I can have in 24 hours, because that's my average, day of patients. And again, that varies on an inpatient, right? One time you can have 15 patients, the next hour you can have 20, the next, hour you're back down to 14. So a lot of finance uses that midnight term of like heads in the beds at midnight to help determine that, because you got to start somewhere.
Thank you.
You're welcome.
All right, I think the last question that talks about additional resources. So if you recall last week, one of the things that I highlighted at the beginning is that this course itself is that reference materials for you. There's not a book that you can order on Amazon as an example that says, here are all the things you should learn, or here's a book of questions for you for the CNML review course of review test. That's not how this course is built. So Tony in it added some additional references for you to use for that. When you purchase this, there is a practice exam that comes as part of that package. You can do those questions. That helps you understand how questions are written. Was based on the same framework as the actual test is written. So you can use that, but once you hit the submit button, it's a one-time deal, and then you will get the rationale for all your answers, but you can't retake it and resubmit it.
And then the last question is, you take the total FTEs and the worked hours to determine staffing. You would take the total worked hours and your patient census to be able to determine that staffing, because your worked hours is going to be based upon how many patients that you have. You have 7.2 hours per patient. So the more patients you have on the census, the more hours you have, which means the more staff you need to be able to take care of those patients.
All right, I'm going to try and dig into the next section. I will tell you in advance that we're going to end up stopping in the middle of the material, and then we will pick that up next week, okay? So I'll get on to the next piece of the puzzle. So this is on human resource management, which is a portion of business skills and principles in the competency framework. I would say that this is where you spend the majority of your time as a leader. So a particular area should become it should be familiar to you, innate to your practice. It should show you the skills you already know, and just kind of building into how to leverage your experience here. We will start off with 2 practice questions. So here's the first one. An emergency department manager has recently noticed that the day shift charge nurse has become irritable and makes negative comments regarding patient employee issues. Which of the following statements by the manager is the best response to this change? And we'll have Tony put a poll for us. Choose the best answer. And Tony, just let me know, I'm not seeing the poll rise as people answers. Just let me know where we are.
Yeah, of course, we're at 56%.
Thank you.
67, 74. All right, awesome. We'll go ahead and share the results.
Thank you, ma'am. All right, so we've got the majority of them picking letter C, with a couple of folks about A, and then a couple of folks on B. So let's move on to the rationale here. So the correct answer is C. Let's talk a little bit about choice B though. So remember here, the statement is the best response to the change. So thinking yourself as the manager. So looking at B, it says, you seem unhappy at work. Are you having any personal issues that could be affecting your performance? Think about those specific words, and what would that specifically cause you to feel if someone was asking that? Are you having any personal issues? So one thing is that you're assuming that they have personal issues, which is one, which may gain you an inappropriate response to address that, so that you're jumping to conclusions, right? It seems too invasive, accusatory. Exactly. That's exactly what I'm trying to get. So it can blur boundaries between being a manager versus a friend sometimes. So this is where information about where your leadership line kind of goes in your communication style comes into play. So very good. Ashley says she had a manager that asked me that, and I saw red. Deflecting the potential problem is within the department onto the employee. Yes, so there's some things in there that you want to consider. It's a great example. A says, I had a meeting scheduled, canceled, excuse me, and would you like me to assist you with some of your duties? This is a temporary fix, guys, and let me tell you, as a nurse manager, you cannot solve every team member's issues, and you can't be in their places all the time. So that in itself doesn't help solve the issue that you're trying to get to, which is why C is the best answer. So the statement provides the solution for ways to cope with increased stress. And that's all you've identified. This team member has an increased stress. You're not saying where it's coming from. You just noted a behavior change, and we want to provide some resources that help them get through that. That could be work related, it could be personal, but that way you're not determining one way or the other, but you're trying to be supportive because you've noticed a change in behavior, if that makes sense. Any questions about that answer? Okay. Next question. Which of the following is the most appropriate time for a nurse manager to consider termination of an employee? So after complaints from the physicians, following multiple separate policy lapses, rarely is human error is generally forgiven in just culture, or after failure to comply with performance improvement plans. People are coming in hot on this one.
Yeah. All right, 77%.
You guys did really good. All right.
Let's share the results.
Thank you so much. So I see here that the majority of us have picked letter D. We have a couple about the following multiple policies, and it looks like maybe just one person about the human culture, human error. So let's talk about that a little bit. Oops. All right. So the answer is D. I do want to talk through about the multiple separate policy lapses. In this case, the caveat I'd like to frame this with is this is a national exam. So it does not take into consideration your specific organizational's processes related to policies and combining things and stuff like that. That may be a specific thing to your workplace. So in this case, when they talk about multiple separate lapses, it may not indicate termination, but it's a process that should be documented along the way. Right. So the key learning here is that when we're talking about disciplinary action for a team member, it should follow a process. So whether there's several policy lapses, as long as you're following a process, then that's the appropriate thing to do. Rarely is human error is generally forgiven in a just culture. If you are not familiar with a just culture algorithm, human error is one aspect of that, but it is still require professional and personal accountability. So there's a system piece of that ownership, but there's also an employee's ownership of their own decisions. They own the decisions they do. So if they make an error, then that's their decision, and that may or may not follow a disciplinary action depending on the algorithm, the way that you walk through that. So in itself, human error is generally not that forgiven process that's listed here. So D is the most correct answer. So after failure to combine with the performance improvement plan, should be specified and structured. It allows the team member to understand the goals that you're trying to reach and clearly indicates to them if they don't meet those goals that termination would be the end result. And usually this is after some other repeated progressive disciplinary based on your organization. So Stephanie said she didn't wish she had much experience with the scenario. That's true. That's why I said this is the area you guys are going to lean into the most and have the most experience with. But that's true. All right, so digging into this material. So the first thing we're going to be talking about here is recruitment techniques. So trying to things that you want to consider when you're looking at what do I need in my department? These questions may really become innate to your work. You may not even give them a second chance, but just to kind of actually walk through that. So how many employees do I need? When are they going to be needed? Are they right away? Is there specific knowledge or skills? So this may be something different to consider if you're trying to change the level of care for your unit. You're adding a specialty to this unit. So you may need a specific group of people to take care of this special population that you're expanding to. Or it could be your standard nurse on that particular unit. And so the skill set and knowledge may be important to that work. And then talks about community needs. So here, how do we look at pieces about cultural competency and pulling that into what you're looking for recruitment? And then it talks about diversity in that same language. Is how do we ensure that the people we're bringing in caring for patients match the community we serve? Therefore, you get that synergistic framework that we have all learned through nursing school and leadership that allows the patient outcomes and the nursing skill set to match more harmoniously to have that patient progress more positively. Looking at your recruitment, sometimes this is done internally and sometimes it's externally, and knowing those differences. So some organizations, all of the work for recruitment may be done at a centralized space with a group of people. Maybe they're called your talent and acquisition team. Maybe they're under your human resources umbrella, or some have a screening process or a low level screening, and then all of the information, interviewing and all that kind of stuff is done with a manager. So it really just depends on how your organization does that recruitment process. So that's one way to look at it. The other thing is this a contracted service, internal versus external? So is your talent or screening teams part of your organization, or are they external, and do you have some contracts that you work through in order to get that service? So thinking of those through two different lenses, depending on your experience. I think it's an important consideration when you talk about recruitment is what your partnerships are with your nursing schools. We're going to talk a little bit more about that a little bit later, but knowing that that is a real clear pipeline for new nurses coming into your organization, and leveraging those relationships and experiences to ensure you get a really good nurse potential into your unit. And then those methods. So do they do things like posting through Indeed? Are you able to go through your professional organizations depending on where you go, where you do that? Are they relying on just posting to your external website for careers? Do they put things into professional literature magazines and things like that? So those are all the ways that can happen. And knowing what your organization does, how to escalate those when you're not getting the right candidates, where some cost or dollars could be spent in trying to get better candidates through attendance of conferences where we have the big booths from your organization. You're like, hey, come to me. I'm looking for nurses. So think about those kind of methodology around to that. And then evaluating the effectiveness of that recruitment program. So Ashley alluded to some recruitment costs and benefits, but then thinking about what I've mentioned before is like, if I spend $1,000 by running a specific ad or paying some kind of fees to the ARNN organization because I need OR nurses. That $1,000 of return on investment is going to give me some more qualified nurses that maybe stay longer term. I have a shorter time for orientation. I'm able to onboard them. They fit into the crew a little easier, may offset some of those costs. So thinking of something like that as you leverage both pieces of the puzzle to make sure you get really good candidate flow. Time to required to fill in openings can be also a data point you can use to help with understanding why you need some of that premium labor that actually refer to whether that's travel nurses or internal travel team or paying premium pay helps with that business case for that or justifying that change in your budget. So that is one way to look at things. And it also helps to understand the efficiency and the effectiveness of that team as well. So that's one thing to consider. Evaluating recruitment quality and quantity is what I was referring to about candidate flow. It's really important that you get the right people for the position that you're trying to do. So those are some things to consider. And then I mentioned open communication with your academic partners with the nursing school graduates. That can happen locally with like your instructors on the unit who bring nursing students in, making good relationships and with partnerships in there, having open conversation about the students on there, allowing them those experiences will really go a long way. It could also be done at a more executive level if you have the ability to be a faculty and do some part-time teaching or adjunct faculty work. That allows some partnership there. And then your CNE or someone like Ashley who builds these relationships through the deans of nursing schools, allowing those folks to come into your organization and to have nursing students and helps foster those relationships. So it can happen at all levels, but knowing that it's an important part of the team. And then the recruitment of the people you bring in also affects the work environment. So if you are having a really long extended time to fill or good candidates, that impacts that work environment negatively because if working lots of overtime or working shift, that in itself has some negative impact. So that understanding that impact with these other factors can help explain some things to your team, but also understand what your team may be going through from their perspective, from a stress perspective. I had a comment in here. Fun fact, usually the recruiters may also have access to some headhunter companies that can use to fill difficult to fill positions. I found that they don't like to advertise it because it costs money, especially, yes, but it is effective. I would agree with that. And I've seen this more at an executive level position, but I could see why we would leverage that, Ashley, for some really hard to fill positions or unique things. Ashley, have you had some experience with that as well, maybe?
Yeah, for some, again, higher level leadership roles that we do use it for, just because of the expense that goes into it, right? When you're always trying to balance that a little bit.
Yeah. That's a good point, though. Thank you for sharing that. Moving into staff selection for interviewing. So these types of interviews are here for interview types are here for you to kind of be familiar with. You probably use any more or a combination of the two. I'd like to say at this point, video interviewing has become much more prominent today than I did when I first started teaching this work. We really didn't rely on much of that anymore, but today that's really part of our normal practice. So interesting enough how those interview techniques have shifted. So how does a candidate, as an example, really showcase themselves and the work and the interest for you to move on to an in-person interview? How does the person interviewing them get enough information and understand how to elect enough information to say they're a good candidate or not? It really changes that. That's right. COVID has really changed that world for us. The things that I want you to know here is that behavioral-based interview questions are still the gold standard. So understanding their experience will shape the way they behave on your unit is really the gold standard in asking questions, style of questions to ensure that you're getting the right candidate for not only a culture fit, but an experience for a team building and that kind of work that you want to work through with this process. And then I talked about that. And then it's some illegal questions. So if you are engaging a panel interview with some peers, which is another great practice. So maybe it's folks from your unit practice council, maybe it's an assistant nurse manager, maybe it's your education team as part of that interview, making sure they understand how to interview a candidate, what things we do and don't ask, understanding what illegal questions are and helping them understand that piece of the puzzle. And then sticking to that standard framework for your interviews allows for consistency. So you want consistency across the interviews. You want a standard formatting and rating system so that that can be spoken to. If a candidate's not selected, there's some standard work around that. So Iris, you asked about quite illegal questions, probably things you would never think of, but things are you married? Do you have children? Will this impact your ability to be on work on time? Have you ever been fired before? Like, most people don't ask those questions, but that's the kind of thing they're alluding to.
Are you pregnant? Are you going to retire in the next 5 years, right? Like, I mean, all those questions,
all those kind of questions.
Discriminate against somebody.
Yeah. Right. Iris, does that make sense to you? Irish. Cool. Okay. Let's make sure I answered the question. Okay. I'm going to move into the orientation program. And I think we help shape orientation programs. We're an integral part as a nurse leader. You may not be leading the day-to-day work around this, but understanding the framework from which orientation programs are built and understanding best practices around it is where the role of the nurse manager is here. So its true purpose is to give a favorable impression of the organization and job. It provides general organization and job information. So think of your very first day on site. So every employee in your organization goes to this first day thing, right? So, hey, welcome to so-and-so. These are our philosophies. These are our rules and policies. This is where you park. This is all like your HR benefits. So thinking about that framework is that first thing. That's where you get the first impression of the organization. You enhance interpersonal acceptance. If you can think about the first time you came onto your organization, you may have met some new folks. And today I have an example of that. I met this wonderful gentleman who's in our IT or IS department. We joined the organization on the same day. We happen to work at the same facility. We pass each other's in the hall, and I connect with him often to say how things are going. Where are you today? Is it cool to think we've made it a whole year? And so there's where that initial connection comes from with someone that you may have met during that first day. But it continues on accelerating socialization and integration when you get onto your unit. So think about then your unit culture, that first exposure or interaction with someone like Ashley, who's the CNO on the unit or for the organization. Then you start understanding nursing philosophy, what your role expectations, what the nursing strategic plan is, what our key metrics are, and that kind of sets that framework. Then you talk about employee performance, and then you start talking about productivity, and that's where that layered approach from an orientation program begins. So something you probably do every day, you just didn't break it down into all these parts, but something to think about. Now there's different layers of orientation, you would say. So there's folks that part of a transition to practice program. So some of them, you may know that as a residency program or transition to practice, depending on how your organization's framework. That's one set of organization that's specifically targeted to our brand newly licensed nurses. You may then have an arm or an area where experienced nurses can go or can follow through on a track. So if I have my clinical background is pediatric emergency medicine, if I tomorrow wanted to decide to be a labor and delivery nurse, I could take my years of experience as a foundation, but then I can jump over to L&D, and you have a pathway outlined for me to gain my labor and delivery experience that builds on my experience as a registered nurse. And that looks differently than the one that you would put me into if I was a brand new nurse coming into L&D, as an example. Some of these programs are based on needs assessments or tools you may do. So some organizations have a pretty extensive needs assessment that happens at the beginning of their onboarding process. Some organizations use a needs assessment tool throughout their career, and that helps them build other programs for professional development. We can talk about that in a few minutes. The next layer here listed is departmental stuff and then unit specific. I'd say that the differences here is the unit level is generally like a general orientation that probably every team member gets. where the clock code is, where do you park, what's the rule for putting in your schedule, that kind of generalistic work, you know, a 30-minute lunch, you get a 15, you know, you could get a 15-minute break, you know, that kind of things. Please don't use your cell phone in the patient care area. Please make sure you wear your uniform, you know, general stuff. And then the other piece of that is unit specialty stuff, where I would say is more specialty skills. I work in labor and delivery. My orientation has this added skills. I work in pediatrics. It has this added skills. I work in ICU. It has this added skills. So think of that specialty added education on top of a department education is where they're coming from here. The information they're trying to share here is that when we build orientation programs and push people through that, two things to remember. Try to avoid information overload. If you remember the first time, even like Ashley and I have had recent experiences joining a new organization. We've had lots of experience behind us, but you're still drinking from a fire hose those first little bit of time, right? So trying to avoid that information overload is really key for their success and their ability to process the information you give and then give the outcome you're looking for. Super important when you're talking about newly licensed nurses, as they're really transitioning a lot of pieces. So the way you can break that down would make them most successful. And then they talks about reduction in patient loads in order for them to understand the skills and build the skills versus giving them a full patient load and expecting them to manage that. And with time management skills and stuff from a clinical level gets really challenging. So those are some best practices. The thing I would talk about for a leader, weekly progress with a preceptor, yourself and the education team is super important. It really helps identify practice gaps early on that can be easily dealt with development. It can also help identify cultural team member behaviors that are not going to be acceptable on your unit that you can really intercept early on, so that it's not perpetuating some bad behaviors that are going to linger on your department or add to the decreasing morale or anything on the unit. And then that way you'll be informed. So at the end of this orientation, when you expect a productive nurse to be on your unit, for the team to say, oh my gosh, she can't come off orientation, or he can't come off orientation. They're not ready. They're not safe to practice. They did all these things. You never want to be shocked at the end of that process. So having a real good engagement early on will prevent that. Preceptor programs, I think this is an important piece here to talk about. What it does is the definition here, just for the setting, the context here, is that provides a framework to support efficient and effective integration and enculturation of new staff. That's really what a preceptor is there to do. It's important to build some things for a preceptor to be really successful at it. These include education on adult learning principles. How does someone learn? How do you reinforce content? It may be a little bit different than what they've done before. Learning styles helps out a lot, whether you're a visual, tactile, or a written learner, and that's the way you prefer your information to be. There may be a selection process you use for preceptors. But I also would challenge to say, I think our philosophies about precepting has changed a lot over the last several years, in which preceptors now can look differently than they used to be. So we used to have an elite group of people. That's all that did precepting. We didn't ask anybody else to do it if you didn't fit the mold. With our potentials and turnover and trying to fill vacancies, it's really now every nurse's responsibility to kind of precept in some capacity, and that may look differently, whether that's a nursing student on the unit, it's someone who's doing their practicum with you, it may be a fill-in preceptor who's filling in just for one shift because their primary preceptor is off the unit or out sick that day, you know, that kind of work, in addition to your long-term preceptor. But everyone really, as part of our responsibility as a registered professional nurse, should be precepting in some fashion. So we need to be sure that is kind of supported in a way that gives everyone confidence to do successfully, but could give some guardrails to help them be successful through education and development, which we're going to talk about next. And Ashley, you have a comment in here about research building orientation, skill build orientation rather than patient loading. That's absolutely correct. Our organization uses a framework like that, which builds some skills for several weeks. They do those skills throughout the unit. That's all they focus on, and then they continue to build from there. It is a great new best practice out there in the literature, so I'm glad you mentioned it. I talked about development, that preceptor program. So this really helps to facilitate the one-on-one relationship. It is important that the people who are precepting can understand what coaching and real-time feedback means. It is important to help that nurse grow when there's an opportunity to change practice, to use best practice guidelines, or to reframe a way that an approach was done to help that nurse grow. It needs to be done successfully and consistently in order for us to be successful. Staff development we talk about, and I can't underscore the importance of recognition. Our long-term preceptors really dedicate a lot of time and energy into making sure we have successful folks on our units. And any way you can recognize them, whether it's stuff at the unit level, that could be through the benefit of attending professional development, whether it's certificates or, a special pin. It could be compensation changes. Recognition in general for this group is super important. Ashley, have you ever done anything special for your preceptors in your area? I was curious, and then I'm going to ask the group.
Yeah, I mean, besides the whole pay and all that kind of stuff
Yeah.
too, right? But just like an annual recognition of them too, because it is extra time and effort, and it does take a skill set to be able to do it, right? So recognize, I mean, not everybody, even some people that raise their hand to be preceptors, we don't want all of them to do it either, right? Like, so you got to have that right person and that right fit and recognize them. Again, some of them like publicly, some of them don't, but usually on the unit recognizing them too.
Yeah. Anybody else do anything specific or fun for a preceptor? Oh, a thank you card. I love that.
Mm-hmm.
That's a good one. Precept of the Year award. That's really fun. They get a special parking spot and extra goodies. Laura, what a great way
I like that idea.
That's really cool. Biennial breakfast for preceptors. Go, Ashley. That's a good way to recognize them. This year we onboarded 26 nurses. We used unit budget to buy preceptor gifts, which was basically for the entire team. We sent bravos, electronic recognitions, and the orientee mentions them in specific in their check-ins. That's really cool. That's really great. You bring up something else that could consider best practices is feedback from the preceptor. So not only does the preceptor give feedback about the orientee, but the orientee has the opportunity to give some feedback from the preceptor to help that preceptor grow. I think that's a good way to have a bi-directional communication for peer development to consider. All right. We're going to get through one more slide and then we're going to hold. So we're starting to do this work about retention. And we understand that there's a lot of work done in organizations. You read a lot in the literature about how important retention is. These are some things that probably is pretty standard now. Historically may not have been, but I really feel like this is kind of standard work regarding that there. So professional growth opportunities include things like tuition reimbursement, academic partnerships. So where can I get my education maybe less expensively, and or it provides a flexible schedule that allows me to still work full time and get my education at the same time. Some organizations are providing career guidance built in within their human resources or talent management teams, allowing a clinical nurse to say, hey, I want to further in education. Hey, I'd like to explore the leadership path. Hey, I think it's important for me to be part of the track that's going to be in like a nurse practitioner, like that practice area. And how do I get there? And it provides some guidance on that. And then there's transitions into practice. And what I meant here is about I'm wanting to change careers. I'm changing specialties. I'm changing locations. And how do we help our clinical teams get to those spaces and get those new skills when that happens? Recognition comes to play. There's lots of things I think our organizations do overall. So from DAISY recognition to, I can think of certification days, to our healthcare weeks, to our nurses day celebration. So any and all that recognition. But I think what I want you here is that the daily intentional recognition of your nurses, I think goes a long way. And so the intentional time you take when you do your rounding, when you do your check-ins with your nurses about, hey, you've made a difference and here are the reasons that I've seen it, I think really goes a long way. Some nurse leaders like to do thank you cards, handwritten things like those personal touches, I think make a big difference when it comes to retention, team culture, and what those employee engagement scores are telling you. And relationships, not only with yourself, your charge nurses and the physicians and their own peers, really plays a large part in that work. I think you may have seen some of that in employee engagement scores, like I talked about, but some other ways where your organization is kind of leaning into things helps shape that work that you're doing. Yes, staff will remember the small things for sure. All right, I'm going to pause here before getting on to the next slide. We're at 5 minutes left of today's session. We've learned a lot in this session. So these for next two are kind of packed full. Wanted to give you just a few minutes to say, is there any other questions about the material we've covered so far? Is there anything else we can help you with before we see you next week? Did I bore everyone to tears? Are you all asleep? Just wondering. Okay. Thank you. Just had to put it in there. All right. My CNO likes to call out Bueller. Bueller. Anybody know that? It's showing my age a little bit, but maybe it'll get to a good laugh. Okay. All right. So yeah, I did get some laughs. All right. Cool deal. Thanks. Okay. So a jam-packed session. We look forward to seeing you all next week. If you have any other questions, feel free to put those in the chat. Tony will download that so that we're prepared for next time. We did follow up and let you know our slide decks for future sessions should be available for you in the LMS. So please, if you feel free, you want to download them for the sake of taking notes, let's do that. And then remember, after each session, the recording and then the faculty version with, quote, the answers will be posted in the LMS, usually in about 1 to 2 business days after our sessions. I see Amanda says finance could use more attention. So we will make sure we make time in our last session to go back to finance and we have a couple other scenarios and then just general questions. What I'd say for the next time is start to lean into your finance team. Find a finance person that you're comfortable with. Ask them questions. Look at your own budget. Start poking into things you maybe not have done before and ask questions about what you see. Run into colleagues who have been doing this a long time in your organization and ask them questions about budgeting and finance. It may help you go a long way with your preparation. All right. Y'all have a wonderful day. Thank you so much for spending time with us.
Bye, everybody.
Bye.